I do work at AREP Laboratories, as you may have guessed, with Karen doing the introduction. I've been with AREP for a lot of years. So I've been dealing with clinical laboratory information technology as a profession also for many years. And I encourage all of you, as I'm going through this, to ask questions. You don't have to wait till the end. You can ask questions as we go throughout this presentation. Okay, so what I'd like to cover today, learning objectives, what are we trying to accomplish here? Learn a few things about a laboratory information system. For starters, integration, data integration, you might want to call it information integration. So a laboratory information system, of course, is a computer information system, and it has to share data with a lot of other information systems out there in healthcare. So we're going to touch on that, talk about that a bit. Also the basic functions. So since it is an information system, what are the software functions and features that you'll find in a typical LIS? We'll review that. And then we'll talk about a product review. What LISs are out there available for purchase, for implementation? We'll go through that, and we'll talk about selecting and implementing a laboratory information system. It's an easy task. It's just like installing Microsoft Word on your computer, and we'll find out how easy it is after this presentation. And actually, I'm joking. It's much more difficult than that, but we'll hit that. Okay. So, for starters, I always think this is an interesting quote or statement to put up here, that the importance of the laboratory role in healthcare. So, on the diagnosis and treatment side, when clinicians are polled and asked, well, what information, what's the most common type of information you use out of the medical record, which of course now is the electronic medical record, this individual was saying 80%, because it came from a JCAHO study or survey or something. So you see, there's been a lot of different studies, you see anywhere from 70 to 80% of the clinicians surveyed say they rely on the laboratory data in the electronic medical record. So that's where the vast majority of their information is coming from. So it shows the very, very important role that you're going to be playing in the future with your careers and the positions you'll be in the laboratory. Okay, so on to integration, data integration or information integration. So the LIS is not a standalone or an island of information. It has to share information in a lot of different directions. We'll talk about two directions. So data going out of a lab system goes to a lot of various different clinical information systems in the healthcare arena. By the way, a little note, might be interesting to some of you, that probably the oldest clinical information system out there is a laboratory information system. And you could probably imagine why. You know, labs for years were overwhelmed with paperwork, and assimilating those paper charts and distributing those was a big task. So one of the first areas they tried to automate in the hospital with computer systems was the laboratory. So they've been around for a long time. Laboratory information systems are considered to be mature information systems. Okay? So getting data out of the lab system, where does it typically go? Well, it obviously goes to the hospital electronic medical record or electronic health record, as the government likes to use the term EHR instead of EMR. That's a very common place. Now, some healthcare systems will have their lab system and their hospital EMR as part of one big system. Epic is a good example. Cerner is a good example. You may have a Cerner EMR called PowerChart, which actually was installed here at the hospital. And the lab may be using Cerner's lab system. So it's all part of one big database. But this slide is showing it as though the LIS is a standalone information system, because that's typically the case that you'll encounter. The LIS is a separate information system from all the others used in the hospital or elsewhere in healthcare. So another typical type of interface or information exchange you might see with an LIS is with the physician EMR. So a lot of doctors have their practices, they have their own individual electronic medical records in their practice. And more hospitals share their records with those doctors, especially when those doctors have privileges to practice in that hospital. And of course, we can't leave out the reference labs like ARUP. That's very common today. We have many interfaces set up across the country with different hospitals' laboratory information systems. Very common. And also, public health agencies. Right now, ARUP as a reference lab has to deal with the different health regulations in 50 states. And it does vary state by state. And I'm sure Karen may have touched on that. That's the challenge of being practicing medicine across the country. You get to deal with the different states' regulations. So we have a lot of information exchange with the different state health agencies, and sometimes with county health agencies, and sometimes with city health agencies. So it's a challenge because they all want it in a different format, in a different way, and a different timing. So we have to deal with all that. But it's a very important part of laboratory information exchange. And of course, patient PHR. You don't see that as much today. It's gaining ground in terms of integration. But Microsoft Health Vault is a good example of a personal health record that's out there. Does anybody have a Health Vault account? But Health Vault is by Microsoft and it's independent, and you can have data pushed into it if your provider has that ability to push data into Health Vault. Currently, ARUP, for example, is a lab. We do not integrate any of our data with any of the personal health records out there right now. And one reason is, it's like I said, it's very possible that it's gaining traction and may gain more traction. A lot of times they integrate with the hospital EMRs because the PHRs want all the medical data and not just lab. Although lab is typically the first type of data they push out because that's what patients are looking for. Where are my lab results? What do they look like? And typically when you look at, from an IT perspective, when you're looking at exchanging information in a laboratory environment, the data they want first, if they do have to prioritize it, are the results. So you'll do this first. You usually push data out of the lab system before you ever pull it in from a different system. But you do need data into a lab system if you want to integrate it well in the healthcare arena. And what are typical sources? Well, they're almost the same ones from the last slide, right? You have your hospital system. So you're going to have some type of a patient admitting system or financial system that will feed all the patient data into the LIS so that the LIS is ready for electronic order on that patient because it already has the patient data. And hopefully everything does line up so you get it in that sequential order. You get the patient data first, and then later you get the order electronically into your lab system. Over here on the right side, hospital CPOE, same thing. It's part of a hospital information system, or EMR, CPO, clinical provider order entry is the acronym. So that's where most clinicians do their ordering, whether it's lab, radiology, pharmacy, whatever. It's the CPOE function of an information system. Physician EMR, again, if the hospital is really integrated well with the doctor's offices in their area, in their community, you'll have orders maybe flowing directly in from the doctor's office, their EMR, into the laboratory information system. And the same with the reference lab. We're pushing results out constantly. As I stand here and speak right now, we have results being pushed out to various lab systems across the country. Integration inside the lab. So you can start to gather here from this discussion so far. There is a lot of data integration going on with the laboratory information system. You always need that expertise in an IT group that manages and administers a laboratory information system. Either you have it in your group or you're contracting a lot with your LIS vendor to do this type of data integration with, which is what a lot of hospital labs end up doing. They just pay their LIS vendor to do a lot of this. But inside the lab, of course, we have interfaces with analyzers. And I don't know what the count is at ARUP right now. Some of you may know. I think it may be over 60, 70 different types of analyzers that we have interfaced to the LIS. And of course, something that's similar but not quite the same is middleware. And has everybody heard the term middleware used in the concept of the lab? Well, that's typically software that sits between the bench or an analyzer and the LIS. So it might do a lot of heavy-duty calculations, it might do some QC work, and they typically refer to that as middleware. It sits between the analysis process and the laboratory information system. And we interface quite a few of those. As a matter of fact, we actually develop a lot of our own middleware at ARUP. We purchase some of that and we develop some of it in-house also. And it's very important to get that interfaced into the LIS. So we're pushing orders down to these devices in the software, and we're receiving results back. That's typically what we're doing. So to get to the basic functions of a LIS, so the functions of any software system basically tells you what the purpose of the system's all about. And I like to break it up into 3 categories, and I think that's what your chapter in LIS did too. The author broke it up into 3 categories: pre-analytic, analytic, and post-analytic. So what do you do in those 3 areas with an information system to capture the data or the data flow through a laboratory? And that's the challenge. It's your typical LIS is considered a workflow type of information system. It is designed to follow the workflow of a laboratory, hopefully from A to Z, from beginning to end. And these are some of the features that we'll cover in a little bit more detail as I go through this. Okay, order entry, one of the key pieces. Now that first note up there in the upper left is there because I want to make sure everyone understands that order entry, like was discussed in the previous slides, is typically done by a clinician or their staff in a different information system. That's how it's typically done today. And then it flows into the LIS. Okay. But I use this as an example. This is actually an order entry screen, a snapshot of the order entry feature in an LIS. That's ARUP's PathNet Millennium system. But the features are basically the same. So whether it's in the CPOE or a hospital information system or it's in a lab system or LIS, the features are going to be similar. So you need to be able to find the patient, number one, to order a test. And so they'll have search features for that. There's, of course, fields or data elements to enter the specimen information, some of the collection information. And obviously you want to be able to look up that test or search for that test in various ways. Sometimes by the code, you may have memorized the code, or by name or by mnemonic. So there's usually various ways to search for the given order test. Ask at order entry questions. That's also an important thing. You know, some tests are set up that they prompt for certain information when they are ordered, like maybe height and weight of the patient. And then any special instructions will be there too on the screen as they order that test. So we all have to remember that orders for a laboratory is the way that the clinicians request laboratory services. They create a lab order. So that's why you hear the term order all the time. Now, if you go walk up on the floors or whatever, what are the clinicians, the nurses, the docs, how do they typically refer to the laboratory service? The labs, right? Where are my labs? Somebody go get my labs. Okay, so staying here on the pre-analytic side, talk a little bit about collection and tracking. So now that we have an order created, electronic order, we need to track that for collection. And that's what this is about. Specimen collection, so you might have a specimen coming into the lab that's already been collected by a nurse or someone else. It comes in. You don't have to dispatch a phlebotomist. Others are queued or put in the backlog to be collected by a phlebotomist. So you have to have in your LIS the functions to create phlebotomy lists. That's basically their to-do list, right? I have to go to this floor and this nursing station and that floor and this to draw from these patients. And since the phlebotomist always usually report up through the laboratory, this function or feature is found in LIS. And so all that information is pre-established. So when the laboratory management team works with the nurse and hospital management team, they decide, okay, when do the phlebotomists need to do their draws? What are the typical rounds? What areas do we have to go hit or be present in? And they set that up in the system before, so this information can be automatically generated for the phlebotomist. And of course, once we start receiving those specimens into the laboratory, the status of the order has to be changed so we know what's going on with that particular order and the specimens associated with it. Okay, I did have one more visual there, and that's just a label. I just want to make sure everybody can see a picture of a label. Right now at ARUP, we use two different barcodes on our labels because one is for an analyzer or a scanner, and the other one is for our automated track system that carries the specimens around and deliver those specimens to sorters. We are trying to move to one barcode that can be that every device, every instrument, all the tracking automation systems can use. Okay, now moving on to the analytics side of the functionality. It's more about workload management. So now you have all these specimens flowing into the lab. What do you do with all of them? Well, it would be nice if you could just pick one out at a time and say, I'm just going to do this one and go work on it. And when I'm done with that one, I'll pick up the next one. Of course, that's not how it's done in today's laboratories. There's a lot of volume, like you see all those purple top tubes, and we have to be able to deal with that volume. And those functions are built into your typical LIS. So for example, all the tests you set up in your LIS are assigned to a laboratory section. That's where the analysis is done. That lab section is responsible for that testing. So that's all clarified in the LIS. And so we know how to assign those orders when they come in. And that can even vary by time of day. It's like during the day shift, you may have enough staff in one lab, you route all the tests to that lab, but at night, in the middle of the night, you may have a reduced staff and you change that routing so that now that test is assigned to a different laboratory section. Okay. Also, priority order is important to know. If a clinician orders something stat, of course, we want that to bubble up to the top of our workload, right? So we get to those first. Of course, the LIS produce worksheets, and those can be either online that you just look at the screen, or you can print those out. I know a lot of labs at ARUP like to print those out. They scribble a lot of notes and other things on their worksheets. But that's very important because that lines up your work for you. That's basically gives you your priority order. And then they use that to establish runs. So they batch up the work. It either goes on the analyzer or goes to a bench for analysis. And that they can do that obviously with the LIS functionality that's there. And batching. Batching is just the concept, basically the same thing as a run. It's just that you may want to do everything with that batch at the same time all the way through result entry. And I'll touch on that in a minute here when we talk about the result entry function. And here it is, result entry. So this is what some of you may think is the key thing in LIS, because after you've done your analysis, you have results and they're ready to go, be reported to the clinicians. And there's many different features in result entry in your typical LIS. These are some of those. I won't cover every one, but obviously there's things in there for quality checking, different functionality. Again, these are a lot of things that you pre-establish in the LIS, meaning you go in for each test, you set up parameters and say, I want this test to behave this way in the LIS. Calculations, there's certain result types, for example, that it will automatically calculate a value for you based on the other analytes that you've entered on the screen. It'll take those behind the scenes, it performs a calculation and displays it on the screen for you. Auto verification, very popular feature in the last 10 years, I would say, in LISs, in that if a result analysis is done on a device, an analyzer, it can flow into the LIS, go through some checks, goes through some rules, and if it passes all those checks, it's auto-verified, meaning it's available for reporting once it's stored in the database. and rules. Every LIS today has basically a rules engine. There's a lot of these things going on in the background so that med techs and technicians and others don't have to do certain things in the LIS. A good example might be, and a common example is, you might have some type of a screening test, and that screening test is positive, and you always want to order a confirmation test. The LIS, you can set that up in the LIS so it does that automatically. So you don't have to remember at the end of your run, okay, now I had 2 that were positive, I have to go manually order this confirmation test. The LIS can do that for you. And many other things. And result correction. I know none of you ever make mistakes, and we don't enter results incorrectly. But in case you do, there is an error correction feature in all LISs today. Okay, moving on to the post-analytics side. So if all of you are med techs and you've done your analysis, you've wrapped things up, do you have to be concerned about printing those reports out and faxing those to the doctor? No, not for the most part. That's done by the LISs and other systems today. So we talked about that integration, and that's where that comes in. Most all results now go out of laboratory information systems electronically and flow into some other information system. A good example, like we talked about before, is the electronic medical record. So the clinicians have the opportunity as soon as possible to view those results. So that's how reporting is done for the most part. However, LISs of today still have the ability to print paper charts, because we still have to produce some paper charts and perform the faxing function to get those to the right people. And so there's a lot of different ways you can format those reports. Those are all parameters you configure in the LIS. And you place them in different sections. You can label the sections differently. If you don't ever want micro results mixed with something else, you clearly delineate that on the report. There's a lot of different options in reporting. And of course, if you do integrate to another information system with your results, a lot of that reporting is done via web-based type of systems. And does anybody, I'm just curious, does anybody know what the problem with just reporting labs to a system where it's displayed only, like a web-based system? If we only pushed out results to a system that displays it, are there any flaws with that approach? Can anyone think of a...
Maybe you can't get feedback from the client?
No feedback from the client? That could be one. But what I'm thinking about is if you just make it available and you wait for the clinician to come up to their system and display it, they have to wait for that. There are some instances, perhaps like with stats or where the results are really abnormal, that you want to push those directly and get the clinician's attention right away. So does anybody know how that's handled at ARUP?
They come directly.
They call, yeah. So we don't rely on the information systems to do that. They pick up the phone and they make a call. Okay, for the product review, there are several commercially available lab information systems out there in the market. These are some of those. Probably I would consider these to be the most popular. So if you go into any hospital laboratory around the United States, you'll probably more often than not find one of these lab systems. So I have both the vendor's name on the left side and the name of their product there after the dash. I've mentioned before, ARUP uses Cerner Millennium PathNet, and before we installed Millennium PathNet, we operated on their PathNet Classic LIS for 23 years. So we've been a long time Cerner client. One that's really gaining in popularity is Epic Beaker. Now Epic has been around since the late 1970s, but they really focused for many years on the hospital side of things. So they produce what's called an electronic medical record, and that system is very popular. And about 5 or so years ago, they decided that they were going to develop their own LIS, because wherever they installed their EMR, there was always some other system in the laboratory. They didn't have an LIS. So they've developed one and they've improved it dramatically over the last few years, and it is starting to gain traction. We do, as I mentioned before, as a reference lab, we do these interfaces with our clients and their lab systems across the country. And some of those lab systems in the different healthcare systems get replaced from time to time. And typically they're being replaced by the Beaker system from Epic. And you could see why that happens from a business perspective. Epic has a very large footprint out there in healthcare, and all they have to do is go into the IT leadership and the clinical leadership and say, hey, we're doing everything else for you. Why don't you just replace that lab system with our lab system? And that helps them from a revenue side and gives them a bigger footprint in that particular healthcare system. So that system is really gaining some traction. Sunquest and Soft, been around for a long time, very popular systems, very solid systems. The two up there that are really part of, well, I should say three. The three up there that are part of a bigger information system or clinical suite of information system products would be Cerner, Meditech, and Epic. So you can buy an EMR from them and many other clinical information systems, including Lab. But they're also all sold standalone too. Yeah, it's in reference labs. That's a different story. The two largest reference labs in the United States, Quest Diagnostics and LabCorp, they have homegrown systems. And then when you fall down to the more mid-tier reference labs like AREP and Mayo Medical, we use commercial off-the-shelf LISs. Okay, so in talking about the selection of a laboratory information and laboratory information system and the implementation, I just thought I'd go through AREP's story a little bit. This was a big project for AREP. We began a selection process in 2004, and it took 10 months to decide which LIS we wanted to implement. Now, we had been a Cerner client for a long time, I mentioned that before, but we put Cerner on notice to say we were going to consider their new product, their next generation lab system, just like we were going to consider all the others out there. So these are the three we started with. We narrowed it down pretty quickly to Cerner, Soft, and GE Healthcare's LIS product at the time. It was a tough project because we had the PathNet Classic LIS, like I said, for 23 years. So we really had to scratch our heads and think, what do we want in a next generation lab system? So we came up with over 1,500 requirements that we listed in the RFP, the request for proposal. And I noticed the author of your textbook used that term too. So when you go out to make big purchases, you typically work with your procurement office or your purchasing office, and they want to use what's called a request for proposal approach. So you basically put everything in this document that you need in that product or service, and then push that out to the vendors that you've chosen, that you want to entertain a bid from, and you let them respond to it. So that's what we did. Took them about a month or so, I think, to get the responses. I think we gave them 1 month to get the responses back to our RFP. So we finally made a choice. The two finalists were GE Healthcare and Cerner, and then we chose Cerner and signed the contract in March of 2005. So that seemed difficult or hard, but that was just the beginning stage. So now we had to implement it. So we kicked that effort off in June of 2005, and we actually had a contest in the company to give the project a name. We knew it was going to last for a while, and we wanted everybody to have a name to be associated with this project. And so the winner came up with Project Catalyst as the name, and they put a different spelling on the word catalyst. And you can see the uppercase LIS in there. And we had an artist in our group, and she drew these cartoon characters that became our mascots, more or less, for the project. And so they're cats. One has a lab coat on, and it was interesting because if you saw those cartoon characters either on our website, our internet website, or you might see them on posters around in the halls, you knew it had something to do with Project Catalyst. Because we tried to keep everybody really well informed as we progressed through that project of where we're at, what we were doing, and when we thought we might be going live. So we finally did go live in December of 2008. Now, we chose a slow time of the year for AREP as a lab, and we knew that'd be between Christmas and New Year's. And it worked out pretty well for that week, but guess what happened in January? We had record high volume. And that's typically not when you want to implement a new information system, especially an enterprise information system. But we survived it, we got through it, we worked out the kinks pretty quickly. In the first few months, everybody was able to handle the volume, that new record level volume, and everybody in the company did a fantastic job. It wasn't just the IT department. The IT department was basically in charge of the project, but it was everyone contributing around the company that made it happen. And they really stuck in there. So over 250 people were involved. So we involved a lot of different individuals around the company. And the reason the Superman sign is up there is we had this concept of a super user. And we involved these individuals in early in the project, and they were trained before anybody else and really were taught the ins and outs of the system. And we tried to get enough representatives from all the different laboratory divisions so that they would have some experts in their area. Because when you need help with an information system or anything, what do you typically, who are the people you go to? It's your coworkers, right? And so we thought these super users would be really valuable in their areas, and it turned out that's exactly what happened. So we had a lot of educated people out there working in the labs. They spent time training and helping us test this new system before we went live, and it worked out really well. So we chose, like I said, Cerner and Haemonetics. That's the company who makes our blood transfusion and our blood donor system. So we chose SafeTrace and the SafeTrace TX products from that company. And that was the only thing we didn't carry forward from PathNet Classic. PathNet Classic, we had our blood bank, our blood transfusion, and our blood donor system within that system. But we didn't like what we saw in the New Millennium system, so we went to a different product. And of course, they're integrated. We have data flowing back and forth between the SafeTrace TX and SafeTrace and the Cerner Millennium system. So it worked out well. We survived it. We're live. We've been operating it now for several years, and it's part of the fabric of AREP now. Laboratory IT teams are always looking for people that have a clinical laboratory background. So my recommendation is get a few years to several years experience in the laboratory, get to know the processes really well, and then if you're interested, apply for a position in the IT department. And it does help if you take some classes around IT. You know, you don't have to become a programmer, but if you get focused on some of the basics of information technology, that will help. For example, we have a department inside of IT, a group called Clinical Systems, and they are the ones that set up all these parameters that I was talking about for each test, and for the LIS as a whole. They're the ones who are always turning these things on and off and deciding how the rules work. And we typically hire individuals that have a clinical laboratory background into that group, because they also are the liaison for IT for that area, for the LIS, with all the different laboratory departments. So they can speak their language, they know what they're going through, they know at least the basics of their processes, and that translates into their work of how they set up the LIS. So there is definitely career opportunities for people with clinical laboratory experience in IT departments. Some hospitals do it differently. In some hospitals I've seen where the IT people for lab are assigned to the lab, and but what I see typical is the lab IT people are assigned to the IT department, the central IT department, but they're assigned permanently to work with the lab. But that's a good question, and there's definitely career opportunities out there. As a matter of fact, some of the consultants that we hire to do some of this work command a fairly nice wage. There are some that actually are out there do some work independently, so you can hire them as consultants to come in and help you set up tests or different things in the LIS.